Hi, everyone. My name is Dr. Sue Peterson. I'm a specialist in endocrinology and metabolism in Calgary. I'm a diplomat of the American Board of Obesity Medicine, and I'm the lead author of the 2022 update of the Pharmacotherapy chapter of the Canadian Obesity Clinical Practice Guidelines. On behalf of myself and my co-authors, Dr. Priya Manju and Dr. Sean Wharton, I'm delighted to provide you an overview of our updated chapter. In this presentation, I'll take you through some key points in the background and methodology, the medications approved for weight management in Canada, our recommendations, our new pharmacotherapy decision tool, and key messages. So what's new since our last pharmacotherapy chapter was published in 2020? As there is now a fourth obesity medication approved in Canada, semaglutide 2.4 milligrams weekly, we have updated our recommendations as informed by data on this medication. We've broadened our search strategy to identify data in subpopulations with specific obesity-related comorbidities. We have new recommendations for pharmacotherapy for people with obesity and obstructive sleep apnea and with obesity and non-alcoholic steatohepatitis, or NASH. We have a new pharmacotherapy decision tool and table, and we have new sections on other health comorbidities, cravings and control of eating, and quality of life. So let's go through some background and methodology. So why should we use pharmacotherapy for obesity? Well, we know that sustained weight loss is associated with improvements in comorbidities associated with obesity. Healthy behavior changes alone generally achieve only a 3 to 5% weight loss, which is most often not sustained over the long term. Obesity pharmacotherapy can facilitate weight management and optimize health when healthy eating and physical activity alone have been ineffective, insufficient, or without sustained benefit. And we got to remember that the focus of obesity management should be improvement of health parameters, metabolic, mechanical, mental health, and quality of life, and not solely weight reduction. A reminder here that per the 2020 guidelines, pharmacotherapy is in fact one of the 3 pillars of obesity treatment, along with psychological intervention and bariatric surgery. And we use these 3 pillars of treatment as appropriate to each patient to facilitate adherence to healthier lifestyles, i.e. medical nutrition therapy and physical activity. We highlight the importance of treating obesity, treating early, and treating long-term. Obesity medications are actually prescribed far less frequently than medications for other chronic medical conditions, and the adoption rate of new medications for obesity is much slower. Obesity pharmacotherapy should be considered early in the natural history of obesity, as obesity-related health complications tend to increase and progress with time. Obesity medications are intended as a long-term treatment strategy. The clinical trials consistently show us that weight is regained when treatment is stopped. We utilized the same methodology as for the 2020 guidelines. We developed new clinical questions, though, for our search strategy with the assistance of the Merst group at McMaster University. Now, we know that obesity is associated with many comorbidities, and studies of obesity pharmacotherapy in these subpopulations are really important. So we generated questions not only regarding the effect of pharmacotherapy in weight, but also the effect of obesity pharmacotherapy to improve health-related outcomes in specific subpopulations. And you can see here that there's quite a lengthy list of the subpopulations in which we looked for data upon which to inform our recommendations. The McMaster-Merst team used questions to create search strategies. The search was limited to randomized controlled trials or meta-analyses of at least 6 months duration, published since the time of our last literature review for this chapter up until January 2022. 2 Merst members completed screening of the article titles and abstracts and independently selected studies for possible inclusion. Authors conducted a review of full text articles for relevancy based on our search questions. Selected citations were then assessed by MRST for their methodologic quality. The methodological questions were answered, and the level of evidence generated based on the type and quality of the study, and the levels of evidence then informed the grade of the recommendations. Okay, now let's get into some details about pharmacotherapy for obesity management in Canada. The indications for pharmacotherapy in Canada remain the same. Pharmacotherapy is indicated for long-term weight management in Canada for people with a BMI of 30 or greater or 27 or greater with comorbidities associated with excess body fat. For example, type 2 diabetes, hypertension, dyslipidemia, obstructive sleep apnea. We now have 4 medications approved in Canada. We have the existing orlistat, liraglutide 3 milligrams, naltrexone bupropion in a combination tablet, and now we also have semaglutide 2.4 milligrams. In our guidelines, we discuss a number of clinical considerations in starting obesity pharmacotherapy. So we want to identify individualized goals of therapy before starting medication. We need to set reasonable expectations for the pharmacotherapy that we choose and the time required to see those benefits that we are looking for. The targets of treatment need to include outcomes that the patient identifies as being important to them. The targets of treatment can include weight loss, improvement in health parameters, weight maintenance after lifestyle-induced weight loss, control of cravings, and improvement in quality of life. And it's really important that we discuss that treatment is intended to be long-term. Importantly, we point out that obesity is defined by BMI in clinical trials, but this doesn't adequately reflect the burden of adiposity-related disease. We also point out that BMI that correlates with comorbidities varies by ethnicity. So physicians may elect to interpret our recommendations in the chapter with ethnicity-specific criteria in mind. And remember, the treatment response is heterogeneous. Currently, it is not possible to predict which medication will be most effective for any particular patient. Considerations in the use of obesity pharmacotherapy should include goals of therapy, patient values and preferences, patient comorbidities, mechanism of action, side effects and tolerability, safety, existing medications, mode and frequency of administration, and cost. So we now have 2 tables in our guidelines. In the first table, we lay out the effect of each medication on weight loss at 1 year or longer where these data exist, as well as data on the maintenance of lifestyle-induced weight loss. As we're now seeing even better weight loss efficacy with new and emerging medications, in addition to our previous reporting of the percentage of patients achieving 5% or 10% weight loss, we now have added data for proportions achieving 15% and 20% weight loss. Similar to previously, we list out contraindications, common and rare side effects, and possible medication interactions for easy access for the clinician. Now, our second table in the chapter summarizes evidence for obesity medication to treat adiposity-related comorbidities where these data exist. This table reports on many parameters that we reported on in 2020, including effect on prediabetes and diabetes, cardiometabolic parameters, and cardiovascular events, with data updated as informed by our literature search, and of course now with the addition of semaglutide 2.4 milligrams. A continuation of this second table is shown here in this slide, and you can see we've additionally updated with new data on the effect of obesity pharmacotherapy on health parameters, including non-alcoholic steatohepatitis or NASH, as well as effect on physical function, quality of life, and control of cravings, as these are important outcomes of treatment for many people with obesity. Now let's go through our recommendations. Previously, we had 6 recommendations. We now have 9 recommendations, and some of the pre-existing recommendations have been updated as well. So our first recommendation is that pharmacotherapy for obesity management can be used for people with BMI of 30 or greater or BMI of 27 or greater with adiposity-related complications in conjunction with medical nutrition therapy, physical activity, and/or psychological interventions. This recommendation has been updated to include semaglutide, which actually has the highest level of evidence. This recommendation remains the same. Pharmacotherapy may be used to maintain weight loss and prevent weight regain with data for liraglutide and orlistat. Our third recommendation also remains the same. Pharmacotherapy for obesity management in conjunction with health behavior changes for people living with prediabetes and overweight or obesity can be used to delay or prevent type 2 diabetes, with data existing for liraglutide and for orlistat. Our fourth recommendation, obesity pharmacotherapy can be used in conjunction with health behavior changes in people living with type 2 diabetes and BMI 27 or greater for weight loss and improvement in glycemic control. And this recommendation existed before, but has now been updated to include semaglutide. With our increased focus on subpopulations, we now have a new recommendation for liraglutide 3 milligrams, which can be considered in conjunction with health behavior changes in treating people with obstructive sleep apnea and a BMI of 30 or greater for weight loss and associated improvement in apnea-hypopnea index. This recommendation, number 6, is also new. Pharmacotherapy can be considered in conjunction with health behavior changes in treating people living with NASH and overweight or obesity for weight loss and improvement of NASH parameters, with data existing for liraglutide and for semaglutide. We have added a recommendation for which we actually did the original literature search back in 2020, but this was placed in the mental health chapter. We have now repeated this recommendation in our chapter as well, as it's so important that it's not overlooked. Metformin and psychological treatment should be considered for prevention of weight gain in people with severe mental illness who are treated with antipsychotic medications associated with weight gain, and that has level 1A, grade A evidence. And our last two recommendations remain the same. For people living with overweight or obesity who require pharmacotherapy for other health conditions, we suggest choosing medications that are not associated with weight gain. And finally, we do not suggest the use of prescription or over-the-counter medications other than those approved in Canada for obesity management. Okay. Next, I'd like to take you through our pharmacotherapy decision tool, developed to aid the clinician in choosing which obesity medication may be the best for their patient. This replaces the previous algorithm that we had in the 2020 chapter. So first, we start with the patient and healthcare provider considering obesity pharmacotherapy. We then provide information to our patient regarding all available medications. Recognizing that access to medication is a limiting factor which needs to change in our country, we took the pragmatic approach that reflects what we do in clinical practice. Does our patient have access to medication, limited access, or no access? If they have no access, well, we need to advocate for access. If they have access, then we need to consider goals of therapy, including treatment of comorbidities, percentage and durability of weight loss, and patient values and preferences, including cost, frequency, and route of administration, as well as tolerability. We then start medication, and we assess efficacy after 3 to 6 months on therapeutic dose. If treatment goals are met, we continue medication. If treatment goals are not met, then there's some things that we need to think about that might be impeding success, and I'm going to circle back to that in a few minutes. But just to cover off the decision tool, if treatment goals are not met, then we may consider adding or substituting medication. And always we need to periodically reassess the goals of treatment as well as patient values and preferences. We have, in addition, created this table that must be used together with the decision tool to help to guide the choice of pharmacotherapy. So here we've listed each medication, the populations showing weight loss benefit in clinical trials, the average weight loss at 1 year with placebo comparator, the benefit in adiposity-related health parameters in these populations or subpopulations, and a relative indicator of cost. And we point out that there is, unfortunately, no provincial coverage for obesity pharmacotherapy in Canada, which is something that we must continue to advocate for. Now, to round back to our decision tool, and if treatment goals are not met after 3 to 6 months on treatment, in that situation, we need to discuss factors to consider, including assessing for challenges in adherence, tolerability, barriers to health behavior change, contributing psychosocial or medical issues. We need to consider the patient's prior weight trajectory. And remember, that should also be considered in determination of treatment goals from the outset of therapy. We need to think about what factors could be impeding weight management efforts and/or acquisition of treatment goals. And as stated, we can consider adding or substituting medication if treatment goals are not met. So finally, I'd like to end my review of our chapter with some of our key messages. Pharmacological treatments are an effective and scalable approach to treating obesity, and pharmacotherapy is an important pillar in the management of obesity. Remember that the focus of treatment should be the improvement of health parameters, not solely on weight reduction, and should include outcomes that the patient identifies as important. And finally, remember that obesity medications are intended as part of a long-term treatment strategy. So just a reminder that full chapters of the Adult Obesity Clinical Practice Guidelines are available at the link that you see on the screen. And finally, a note that Obesity Canada has many educational training courses available based on the Canadian Clinical Practice Guidelines. All of these courses have been updated to reflect the updated chapters on pharmacotherapy and also the new update in medical nutrition therapy. Obesity Canada recently launched the Caliber training program, which provides holistic, practical knowledge on how to integrate the clinical practice guidelines into your current practice. So you can visit the website for more information on these programs. And with that, I will thank you for joining us today.